Community Health Improvement Proposal by Phil Pascucci. The community assessment was done with a dual approach. I used the MAP-IT model from the Department of Health and Human Services that talked about making sure you gathered your support and resources, that you found the greatest community needs. Your vision was for health with action steps, and the action steps were monitored and used to show progress over time. We also used the risk assessment, including health hazard appraisal and current recommendations for preventable services. The advantage of this is it supports health promotion and illness prevention. The disadvantages are the reliability of information, the overemphasis on lifestyle versus environmental factors, and possible lack of cultural sensitivity. The population I chose was the Bosnian population in Grand Rapids, Michigan. It is the second largest Bosnian community in the United States. It is aggregated into the white population, so it is difficult to weed out how many Bosnians there are. But in Grand Rapids there's 16,000 approximately, which is about 8% of the population. They immigrated in the 1990s during a civil war in their country. They're a tight cultural group. They do have a newspaper, a radio show, a community center, and religious communities all in their own area here in the Grand Rapids area. They have a strong work ethic. Many were professionals, but they struggle in America due to language barriers. Geographically, they stay close together at the south end of town. The majority are in one suburb. There's a higher than normal rate of heart attacks among Bosnians. The determinants of health for the Bosnian community are the exposure to new foods and fast foods with an increase in obesity. They have a higher than average mental health problems, including depression, anxiety, and post-traumatic stress disorder. They have a higher rate of smoking and alcohol use due to cultural practices. They are unfamiliar with the United States healthcare system as they came from a socialized system. And there is approximately 35% that speak little or no English, which can relate to about a 50% linguistic isolation of people from the Bosnian community. The community health diagnosis are risk of coronary heart disease among the Bosnian refugees related to a higher than average rate of smoking, alcohol use, and poor diet choice. This is demonstrated by the high heart attack rate compared to general population. There's a risk of social isolation among Bosnian refugees related to exposure to the civil war and genocide, and is demonstrated by high rates of depression, anxiety, and post-traumatic stress disorder. And thus also have a risk of decreased health care among Bosnian refugees in Grand Rapids related to language barriers and inadequate understanding of the United States system, as demonstrated by the increased obesity and increase in coronary heart disease. The community readiness and evidence-based research evaluation showed that Bosnian individuals follow up appropriately after they have a heart attack. These are educated people, and if we can educate them prior to their need for service in the community, then we can provide them with identical information and have a preventative effort instead of a treatment effort. The culture perceive healthcare through values and beliefs set by target groups and past experience. The Bosnian population came from a culture of social medicine with knowledge of hypertension, diabetes, and coronary disease. What they lack is an understanding of access to the United States system and their language barrier. Providing information and samples has not decreased preventable disease. Successful strategies focus on socio-cultural and historical barriers. Religion and culture are major components that influence members. People will trust experts from similar cultural backgrounds. My proposed interventions for the Bosnian community include providing language support for all healthcare visits at primary care, at screenings, and also at the tertiary care level. For the community that serves these people, I would suggest web-in services. Metro Health has been the service that's been used in the past for this group, and they would provide a culturally sensitive training for the staff, as well online as well as in person for the outpatient centers and the testing centers. There'd be confidential medical health services. We suggest using phone interpreters for privacy, as the community is very tight and they often don't want the negative stigma of mental health issues to be out in the community. I would suggest smoking cessation classes at the community center in native language. Also flyers throughout the community, including grocery stores, community centers, mosques, and with confidential phone numbers to access the mental health services. The Bosnian community has its own newspaper and radio service available in their native language. With that, I would suggest service announcements for alcohol overuse, accessing care in the community, smoking cessation, health and nutrition tips, as well as ads for classes including all the above topics. These classes would be held at the community center, and we would also have immunization information and disease prevention information, as well as seminars frequently to talk about the access of the United States health system, talk about insurance and how there's cost of care, which from the community they're from, all care was free. Community support would be widespread. This would allow many different people to have smaller parts so that everybody can contribute something, but if one part falls off, it's easier to make up for than if there's just one support. Metro Health Hospital has provided free care when there was regional immigration. They have a strong foundation to support the community with 2 employed physicians that are Bosnian, as well as 14 outpatient services, 3 of which are within 5 miles of this community. The local colleges, there are 4 in the city with BSN programs and 2 with MSN programs. I would suggest that they provide support with evidence-based education, possibly requirements to teach a class, or to at least provide a class topic for the health class, for their public health class. This would allow them to have it translated into Bosnian. It would get them exposed to the culture and get them exposed to public health. The Bosnian Community Center, or Cultural Center, would have the biggest role, as they would provide the expertise in culture and language. They would help to take the education programs provided by the colleges and make them fit into the cultural needs of their community. We have several interpreter services. Make sure that there's a large enough local Bosnian interpreter service for personal service. Provide reasonable rates and guarantee support for programs with language assistance. And finally, the local health department, which must provide the expertise in community health and coordination of education, as well as collect data and validate results, adjust programs as needed, and gather continued support. I provided a copy of the logic model. It shows 2 of the major barriers that we have with the Bosnian community. One is a language barrier, allowing us to have translators in person or by telephone for 24-hour service will allow us to be able to take care of this community at all times. We want them to be able to understand the message and ask questions, and this would hopefully, for the long term, turn out to be a decrease in disparity and economic burden of the first visit being tertiary care, and also reducing the need for tertiary care via prevention and office visits and screenings. The cultural barriers, persons from the community with English language proficiency would need to give us a hand to make sure that we have cultural buy-in to our education and make sure that it's culturally sensitive and directed. The output of this would be the Bosnian community able to understand and appreciate changes needed when culturally appropriate, and this would decrease the disparity and economic burden. It would develop healthier habits in future generations and help them assimilate to United States healthcare services, reducing need for tertiary care. The evaluation model I used was the Rossi framework. It has a list of the stakeholders, which would be the City of Grand Rapids Public Health Department as the main stakeholder and any community leaders. The goal is to reduce tertiary visits as first encounters with healthcare, increase the Bosnian primary care visits, and develop healthier habits within the Bosnian community. The activities would be community education programs that are language and culturally sensitive and appropriate, and a private mental health service to allow the Bosnian community to be treated for the post-traumatic stress disorder. The measurements would be baseline measurements of primary visits and tertiary visits, a qualitative survey of Bosnian people on the U.S. healthcare system. We'd like to measure the mental health patient enrollment, and then a cost versus benefit analysis. To evaluate the program, we would repeat data gathering at 12 and 24 months and use this data to support and adjust programs to meet goals. In summary, the Grand Rapids Bosnian population is underserved as evidenced by higher than average heart attack rates and lack of primary care visits. The plan is to provide broadcast messages, community center education programs, and primary care support that is culturally sensitive and in an appropriate language. Our goal is to increase primary and secondary care visits, decrease the tertiary care visits, have proper use of the healthcare system for preventative visits and proper health screenings, improving the health of the Bosnian community. Thank you.